Welcome back to the Neurology 101 series on the ProPA podcast. I'm Dr. G, and in today's episode, we're continuing our sub-series on dementia with a condition that's all about the overlap, Lewy Body Dementia. Visual hallucinations? Check. Parkinsonian features? Check. Cognitive decline? Also check. Let's unpack this clinical curveball. Did you know Lewy body dementia is the second most common type of progressive dementia after Alzheimer's, but it's frequently misdiagnosed? Up to 80% of patients are initially misdiagnosed with either Alzheimer's or Parkinson's before the full constellation of symptoms becomes clear. Let's dive a little deeper into the kinder patho. What is Lewy body dementia? Well, Lewy body dementia, or LBD, is a progressive neurodegenerative disorder characterized by the accumulation of alpha-synuclein proteins, or Lewy bodies, in the cortex and brainstem. It lies on a spectrum with Parkinson's disease dementia, and the distinction depends on the timing of the cognitive and motor symptom onset. In Lewy body dementia, we get cognitive symptoms which appear before or within 1 year of the motor symptoms. In Parkinson's disease, cognitive symptoms develop after years of Parkinsonian symptoms. Now let's look at the clinical presentation. The classic core features of LBD include progressive cognitive decline, visual hallucinations, which are early, vivid, and often of people or animals, a Parkinsonian motor symptoms, including rigidity, bradykinesia, and a tremor, and fluctuating cognition and alertness. They can also have REM sleep behavior disorder or acting out dreams. Additionally, there is some sensitivity to antipsychotics, and falls, autonomic dysfunction can cause orthostasis and even constipation. So, how do we diagnose LBD? Well, it is a clinical diagnosis. There is no definitive test, but key features help out, including the early hallucinations plus Parkinsonism plus fluctuating cognition. This is a classic triad. Use cognitive screening tools like the MOCA or the MMSE. Brain imaging may show preserved hippocampi, unlike Alzheimer's. We can also consider a DAT scan or a dopamine transporter scan, which can support the diagnosis if it's available. How do we treat Lewy body dementia? Well, we want to consider the cognitive symptoms. So, acetylcholine esterase inhibitors like donepezil may help with this. They also may help with hallucinations and behavioral symptoms. As far as the motor symptoms, we want to consider levodopa with caution because this can also worsen hallucinations. For the behavioral symptoms, we want to avoid antipsychotics when possible. If necessary, use ketapine or clozapine and avoid haloperidol at all costs. For the REM sleep disorder, we might consider melatonin or clonazepam. All right, book med versus street med. So the book's going to tell us Lewy body is dementia plus hallucinations plus Parkinsonian signs. Street med, your patient tells you his wife talks to people who aren't there, has slowed down physically, and sometimes is totally out of it, then fine the next morning. Alzheimer's? Maybe, but when she has those vivid hallucinations of children in their kitchen and starts shuffling, this is definitely Lewy body. All right, so some clinical pearls. Visual hallucinations are early and vivid, not late stage like Alzheimer's. Use cholinesterase inhibitors to help both cognition and hallucinations. Neuroleptic sensitivity is hallmark. Avoid haloperidol. If motor symptoms precede cognitive decline by greater than a year, think Parkinson's disease dementia instead. All right, now let's do some practice questions. A 72-year-old man presents with dementia, vivid visual hallucinations, and mild tremor. Symptoms fluctuate throughout the day. What is the most likely diagnosis? Is it A, Alzheimer's disease, B, Parkinson's disease, C, Lewy body dementia, or D, frontotemporal dementia? Well, hopefully you've been paying attention and you got this right. It is C, Lewy body dementia. Remember, cognitive decline plus hallucinations plus Parkinsonian features equals classic LBD. Question 2. Which medication should be avoided in a patient with suspected Lewy body dementia? Is it A. Donepezil, B. Quetiapine, C. Haloperidol, or D. Memantine? If you said C. Haloperidol, you have been paying attention. Remember, patients with LBD are extremely sensitive to typical antipsychotics like haloperidol and can develop severe rigidity or neuroleptic malignant syndrome. All right, so some final thoughts. Lewy body dementia is often misdiagnosed, but knowing the triad of dementia, hallucinations, and Parkinsonianism can help spot it early. Be cautious with medications, prioritize caregiver support, and remember, what looks like Alzheimer's might be a Lewy body in disguise. Next up in our dementia subseries is vascular dementia, where stepwise declines and small vessel disease shape the story. If this helped bring clarity to a confusing dementia case, send it to your class or share it on your study app. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you soon.